So I told you this morning I was going to tell you a little bit about my new role at Scripps. We realized with the value-based purchasing program, which some of you may be aware of, it's a government program that withholds a percentage of money that we're actually owed by Medicare, and then we get to earn that back if we go through certain hoops, outcome measures, for example, and patient experience. Of that, patient experience is about 25% of that bucket. So as the Scripps healthcare system last year, this fiscal year that's ending October 1, we were eligible to earn back $6 million. Any guesses on how much we actually are going to get from that $6 million? Just guess. That would be good. Another one? Somebody said it. Very close. Yeah, we got $430,000 out of that $6 million that was mine in the first place. Okay, of that $6 million, 25% is patient experience, so $1.5 million that we're leaving on the table. So, unfortunately, patient experience is not going away. When I first heard about this about 10 years ago, an administrator came to our ER group to tell us how to be with patients. And I'll tell you, I was actually very offended. And so I was in the naysayer, which is why I got my job now, because I've said every single excuse that you could possibly think of. It's not statistically significant, this is bullshit, all that stuff that you guys are thinking, I've said. I promise you I have. So this administrator came, one of the key phrases that he wanted us to say to our patients was to go up to our patient and say, "Are we providing you with exceptional care today?" Just sounds like crap, right? Who's going to say that to a patient, right? So we all left that meeting feeling really, one, disgusted that he's never touched a patient in his life and he's going to tell us how to behave. And two, I already thought I was providing really great patient care in the first place, so it didn't go away. And then we were required to call back 2 patients a shift. And then we had to turn this log in. It's like being in kindergarten, like who did you call back and did they like it? But what I realized over time was that I actually enjoyed calling the patients back because I got a lot of positive feedback. I started with the positive people and then I started to call the grumpies because you want to start with the happy people first before you call the grumpies. But over time, I actually get more joy out of doing that than a lot of other things. But then I ran the ER at Rady Children's, and I tell you, every day I saw an interaction that could have been done so much better, whether it was for the patients, whether it was between staff and each other, or doctors and nurses. And so I turned from that naysayer into somebody that actually kind of believes a little bit more in this stuff. So my new job now is actually coaching physicians and staff members. So I've done a lot of one-to-one coaching with physicians. And I'll tell you, I got some really great results in the last few months I've been doing this, but it's only with the physicians and staff that want to change. If you're one of these, like I was, like, what do they know kind of thing, those people that have been forced upon, so the division director says, your scores are really, really low, Dr. Sharieff is going to contact you, I can tell right away when I walk in their office or into the ER to coach them that they're not going to change, right? And so the people that have been forced upon, we did a trial study, there were 6 of them, 2 of them actually went down. What a waste of my time, right? If you're really going to resist this stuff, it's a waste of time. The people that have engaged themselves and said, I really want you to tell me how to do this, have gone up about 55 percentile on average. One of the ER docs has gone from 3rd percentile. She is now 75th percentile. Okay, it works. It's just not rocket science. So I'm here to kind of teach you that stuff. If you want to learn it, if you don't, you can go take a little coffee break. I won't be offended. So up to you guys. All right, we talked a little bit about value-based purchasing, legal consequences. There's a good reason for you to actually kind of start paying attention to this, and I'll show you some of those stats later. But it makes sense, right? If patients like you, they're more likely to give you a break. Right? If you take the wrong limb off, I might not be able to help you. But if it's a communication issue, they're more likely to give you a chance because they know that you're trying, right? Because I'm sure I should have been sued, and knock on wood, I've been really, really lucky. I've been practicing for over 20-some years. And I'm sure there's cases where I should have been sued, and I just haven't. I've gotten really lucky. And that's because you established that rapport at the bedside. I'm due any minute. Every time I go to shift, I'm like, oh, God, I hope it's not today, because I'm due, and I know that. But I've been very, very lucky so far. Everything's about readmissions. We are the window to readmissions, right? So a lot of focus on our ERs now about, do we really need to readmit the patient that was just here a week ago for CHF? That's another thing. So the better educating we can do to our patients, less likely we are to get dinged on that government program I told you about. And market share. Next year, ED CAPS is coming. We're trialing right now. We're actually one of the pilot sites for the patient experience survey. I know they do it anyway right now, but now it's going to be available throughout the country once they get going. And patients can actually go online and start looking you up. You can do this with hospitals right now. Go to hospitalcompare.gov and you can look up your hospital statistics, right? So that's coming. So unfortunately, as I said, it's not going away, it's just getting stronger. So even more reason. I'll tell you why it's hard for physicians right now, and for support staff as well, and physician assistants and nurse practitioners. And those of you who've been, our early grads may not have experienced the pain of it. The older folks kind of want to get out of medicine because it's so frustrating. Those of us in the middle are struggling, and I'll tell you why. There's this triple aim, right, that the government wants us to do. They want us to provide this positive patient experience for everybody. They want us to manage people's health, your population health, and they want us to cut costs, right? And it's a little schizophrenic, right? I can't go running faster and save costs because, you go faster, 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 and make everybody happy at the same time and make everybody healthy. It just doesn't work that way. EMR has come on, lots of information about EMR, how that slows us down. It takes me longer to do a flu patient than it does to see the patient. That's frustrating, right? In the old days, I could go and actually sit at the bedside. And so it is a little bit of a frustrating time for docs right now. And burnout rate for emergency docs, anybody want to take a guess? It's actually 54 percentile right now. Guess who's still in there? Dermatologists. Jan just did this great lecture on derm. Any guesses on dermatology burnout? There's 0. You guys are funny. 34%. That's high for dermatology, right? So if they're feeling the stress, imagine the rest of us are feeling, right? So it's out there right now. It's stressful to be a dermatologist. All right. This is one of my favorite. I'm sorry. Any dermatologists in here? I apologize. I'll whack the surgeons in a little bit. All right. If the other guy's get better faster, then you better be getting better faster than that other guy's getting better, or you're getting worse. I promise you, everybody is working on patient experience right now, not just about the money, but market share, right? So if your people haven't started talking to you yet about your patient SAT scores, they will shortly, right? So you might as well be ahead of the curve. Here are some of the emails from the docs I've gotten. What we started doing is giving specific MD reports, which you guys are probably getting already. And we are pretty competitive, right? No one wants to be at the low end of the totem pole. So just by providing your scores to you, most of the docs come to the middle. And all I ask is you come into the middle. You're not necessarily going to be the 99th percentile, and not everybody can be. It's not possible. But you also don't want to be first percentile when compared to your peers, right? So when we started doing this with several of the ER groups, and they were just impressed that almost everybody is coming on board and at least coming to the middle. And that's really all that you can ask. The middle one, the tips have made me a better and happier doctor. I told you about the struggles right now. If you can have a better day just by using some of these tips, it's worth it, right? Because we're all struggling a little bit. She goes, she gets along with all of our patients, even the drug seekers. That's huge for us, right? If we can get along with our drug seekers, we're happy. And I feel like I care about them more. Okay, that's from one of the ER directors. The last one actually resonated with me. I'm more grateful at the end of every shift than I was 10 years ago. And I have more days when I feel like I've had the best job in the world. That's why we went into medicine in the first place, and all these outside things are kind of dragging us down, right? So if you can do these little things that can bring you around, I think it's worth it. And her quote was, fake it till you make it, because that'll work. So part of this is putting on the show, right? So I always tell my docs, when you come through those doors, those ER doors, you're on show. You don't know who's going to be recording your interaction, right? And there's a couple of cases now you may have heard about in the OR where people left their iPhones on, right? And they recorded the entire conversation. And several $1 million yeah, you can imagine what the surgeons and the anesthesia folks were saying about the poor patients. And so you don't know, who's going to be recording what. Not that that's a reason for it, but if you think about every encounter that you have, would you want that on YouTube, right? And if the answer is no, then you kind of have to do something a little bit differently, right? So just think about that. So honestly, every time I go in a room, I'm on show, and I go in and I just put on that front, and it makes a difference. So fake it till you make it. I'm not telling you to be happy and friendly all the time if that's not your personality, but do pick one of these things I tell you today and go with that. So you want to, we're very distractible. You guys know this, especially in the ER. We interrupt the patient all the time. So I try to be quiet for a second. I try to get them at least through the first minute. And sitting makes a big difference. I'll show you some studies on that as well, and just showing that you're actually interested in what they have to say. You have to sit. If you're one of those people that hovers over the bed, you try sitting. It actually makes the patient feel a lot better about things, even with EMR, and I'll teach you some EMR tips as well. All right. Why do they come to the ER? There is real concern that there's something seriously wrong with them. So you guys know a lot of the complaints are just minor, right? But a lot of times they don't have a reason. One of the things I'll tell you not to say is, what's your emergency today? I'm sure you've heard some of your partners say that, right? So you hear it all the time. So one of my docs said, can you just I have no idea why my scores are so low. Can you shadow me? Very first patient was a 2-year-old, a little bit of a runny nose, low grade, not even a fever, it was 99. And so he goes in, looks at the chart, and goes, what's your emergency today? And I could tell the mom wasn't happy with that answer. She goes and says, he's got a little runny nose, whatever, and then he leaves the room. And I always stay with the families and say, how was that? How'd you feel about this care? And she said, I'm pissed. She said, first of all, I don't want to come to your ER in the first place because I know there's a long wait. I could not get my kid into daycare. I'm a single mom. I needed an excuse from the doctor saying my kid can go back to daycare. That's all I needed, right? And so I said, I really apologize. I go out and bring the doc back in, and I told him that they're really upset with you, and he had no idea. He really wasn't trying to be an ass. He was trying to figure out what they were doing in the emergency department, right? But that question just came across really badly, right? So instead of saying, what's your emergency today, what brings you to the emergency department today, right? Some of our docs that are serving an underprivileged area are asking that question because they don't want the patients to come there. Like, they don't belong in the emergency department, and they really have an attitude with their patients. That's not the time and place to do that kind of teaching. I get it. They don't belong there. You're overwhelmed, but that's not the right attitude, right? So we fixed that problem. Now he's doing great. They think that sometimes going to the ER is faster, and we all know that's not true, but people, they've been waiting to see their GI doc for like 3 months, right? And they finally get frustrated, and their private physician says, oh, just go to the ER. They'll see you faster. That is not true. I cannot get you an appointment if you've been waiting for 3 months. I'm not going to be able to get the GI doc in there any faster than you've already tried. And you guys are well aware of this as well, but there's that perception out there that we can do things faster, right? And sometimes they do. You think they just want a prescription, right? So a lot of times it's faster to come in there. Then there's you guys know all this. There's so many barriers in the ER. We're running from one thing to the next. We're multitasking. We're very distracted. We started doing this thing in one of the ERs now where we do Postit Notes. Because think about how many times you're interrupted. You're doing something really important, right? You're writing a prescription and you're calculating doses. I know we have Epic and all that. You still have to think about the doses even in Epic because sometimes it's off. And I get interrupted, and I'm confused about what I was doing. And so if it's not emergent, we've started asking the nurses and the staff to put a little Post-it note right in front of me, and I'll get to it, right? And I put a little signature or a smiley face if I'm in a good mood, knowing that I acknowledged it, and then I can get to it. But interrupting me constantly, it's really cumbersome. So little things that you can do to make your shift go a little bit easier. And then nonverbal skills, right? People standing at the door like this, tapping their foot, ready to go, I gotta get out of here. And you see that all the time. The patients that are standing at the door like this, you know that they want something from you, right? And what do we do when we see somebody standing at the door? Yeah, I go around in a big circle. There's the rooms right here, and I'm like going all the way around the ER. And my excuse is I'm getting my steps in today, my Fitbit. That's not the excuse. I just don't want to deal with you guys, right? And so that's not the answer either. The answer is to address that patient and say, you look really frustrated, you look angry, you look upset. What can I do to help you, right? What do we do with the AMA patients? We send the poor nurse in there, get them the hell out of here, high five, we're happy, we don't want to go anywhere near those people, right? And so, again, take a step back and think about what are they really here for? How can I be a better person than making everybody go in and get rid of your people? All right, non-verbally, what are they saying? Just the position. Pay attention. I think we're in such a rush that we forget to pay attention to these nonverbal cues. These people are standing. It depends how you stand. I stand like this a lot. Not because I'm bored or angry at you guys, it's just I'm thinking, but is my face matching what I'm thinking, right? Some people have just that grumpy face. You guys have seen them? They just have a grumpy face. They don't mean to be, but they just are. And it brings me down, So look at yourself, I'm serious, look at yourself in the mirror. If you're bringing your own self down, then think about what you're doing to everybody else, So make a change. All right, nice slide on facial expressions and how you feel. All right. Who would you rather see? Right? The guy on the left looks really worried. I don't want him coming in telling me something bad. On the other side, the right-hand side is too happy for me. Don't you think he's a little bit too friendly? So, maybe somewhere in the middle. Pick your style, but something, especially in the ER, I'm having chest pain. I don't want, hello, how are you? I was being coached myself to do a video for my hospital, and I was talking about why people come to see us and trying to put the joy back into being a provider and a physician. And I said, patients come to us in the most vulnerable moments of their lives, if you think about it, right? They're putting their lives literally in our hands. And I said that in vulnerable moments. And the video person said, smile when you say that. And that just sounded so weird to say, vulnerable moments in our life. It just doesn't match what I was trying to say. So make sure your words are matching your facial expressions, otherwise it comes across completely artificial, right? So we talked a lot about body motion, position, sitting makes a big difference as well. And actually, and I'll show you, I think I have it in here. Here's a study. For those of you that want to know why I'm telling you to sit, there was this great ER study that showed that patients overestimate the amount of time that you spend with them if you sit. So 15% overestimation. So if you're seeing your 2 point whatever patients an hour, 2.2 or 1.8, whatever it is, and you sit with the patient, they actually feel that you're spending more time with them. That's huge. right? Plus, take a break. Why do you want to stand all day long? Like, sit down, relax a little bit. You get eye contact with them, right? If you have the same conversation when you're standing over the bed, they underestimate how much time you spend with them by 8%, okay? Which makes sense, because you look rushed. You look like you're in a big hurry to get out of there, right? And doctors always overestimate how much time, so it doesn't matter if we're standing or sitting. We think that we're in there for a long time when we're actually not. On the left, where you see a doctor sitting on the side, that's an end-of-life conversation with a 35-year-old with gastric cancer. And she's having a conversation about what he can eat, what he can do in his last days of life. This is one of our hospitals. It's a disproportionate share hospital. There's no extra chairs in the room. There's the curtain in the middle. And so we've trialed these walking cane chairs, and we're trialing them in the ER as well, because it's very tiny. And so they're like $25. If you have backache, you can use them to walk around the ER as well. It's dual purpose. And then you open it up and you sit down, and you can sit at the bedside. So you can do different things, but make sure you're sitting at some point during that encounter. You can see me on the other side. That's how it's set up at Rady's. Very user non-friendly, right? I'm standing at the computer. I got to make sure I sit sometime during that visit. And I usually do it during the discharge, if you think about it, because I'm sitting, I'm going over instructions, right? I'm trying to get involved with the conversation as well. So find a time to sit, and I also involve them in the EMR as well, right? Look what I'm doing. I'm looking at your vital signs. Hey, let's look at it together. So you kind of draw them into the computer, which could be really disruptive for patients when you're trying to make eye contact and you're on the computer. It doesn't work. All right. So Diane had this slide in here from her talk, just again, standing across arms. It just comes across as you being closed-minded. You don't want to listen to what they have to say. And you're crossing your arms over there. Are you upset with me, my friend there in the green? Okay. No, okay, just making sure. This one study looked at eye contact, right, and how that was perceived. It makes sense. If you make eye contact, not staring somebody down, but kind of social eye contact, people actually felt that you were more empathetic with them. The shorter your encounter, so if you're in and out for those urgent care docs in the room, or providers, and I hate that word providers, clinicians. I don't like that word provider either, clinicians. It's even more important that you make eye contact during those short visits, because otherwise they really do feel rushed, and there's a study to support that as well. All right. So we talked about handshakes. Sometimes you really just want to put your hand on the patient, right? So to have some kind of touch. We're getting into the digital technology now, where there's stethoscopes, all kinds of things, where you don't even need to touch the patient anymore, and everything's done for you. But they really do like that gentle touch, especially if you're explaining something that's sad to them. The other thing I'll tell you just about patient SAD in general, and I learned this when I was running the ER, and I went to P.F. Chang's one day, believe it or not. And the server came to me at lunch, and he said, I'm going to take a break now. Matt's going to be your server, and he'll bring you lunch. And I thought, what a cool thing, Here's some guy who'd have brought me my kung pao chicken. I would never have known who the heck he was, and I probably would have been okay with that, right? But in the ER, we don't always sign over. I hope you guys are doing this at end of shift. Are you bringing, you think about, you should be bringing the new doc with you, and you can say, hey, I'm going off shift. Dr. Smith is going to take really good care of you. And I don't know if we do that enough. If you guys are doing that, kudos to you. We weren't, and we still aren't doing it 100% of the time. But you think about it, that patient has no idea who you are, and then I walk in never knowing the patient and tell them some horrible CT scan news, and they've never met me before. I mean, how would you feel if that was you on the other side of the bed, right? Simple trick right there, start doing bedside rounding, with your co-partners as well, all right? If you're having a stressful situation, there's always going to be people that drive you batty. I admit it. There's some people that I just know. The hairs on the back of your neck go up as soon as you walk in the room. You got to be able to identify those triggers and just to kind of take a break for yourself. Okay, make one point, see how they're doing with that, and stop and take some time for yourself. You'll know it. You'll know whatever it happens to you when you have that difficult patient. You'll know what that feels like. If it's your tense shoulders, if it's you're stiffening up, know what your own triggers are, and you want to leave. You just want to leave that room so badly. So I'll give you this as my case. The parents of a 15-year-old male present to the ED. Actually, the mom, they both came in together, and the mom left. She was upset about something, so dad's left over now. He wants a drug screen for his son. Got normal vital signs, no complaints. He doesn't consent to the form. And oh, by the way, he has a 14-year-old daughter that he wants you to do a pelvic exam on to see if she's having sex. And he's a lawyer, and he said, I want this, and I'm going to sue your ass if you don't do these things. Wow is right. And I had actually just done a favor for a friend of mine who wanted to go on a date with her boyfriend, just so you know. I switched. This was like a Good Samaritan shift that I did, and I come into this, right? So what are you going to do? For real. Somebody's... Talk him down. How are you going to talk him down, though? So you said, talk them down. What makes you think they're on drugs? You know, you kind of get in that conversation. I'll tell you, for me, he was in my face, and my first reaction was to slug him, you know. So I said, let me come. Obviously, you need a little more time than I thought. Let me just finish what I was doing. I'll be right back. And I go outside, and I'm like ready to clobber somebody, you know. And then I thought, okay, let me just take a moment, take a deep breath, because I can't clobber him. And frankly, some of my partners have had very difficult patients, and the first thing they do is start countering. Like, you know, you're not going to sue my ass, blah, 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 you know, and they start doing this other thing, and then before you know it, you're like, you know, like this, and they're yelping from the parking lot, and all kinds of things happen, because you don't like that. We don't like confrontation like that, especially when we haven't done anything yet. You know, if I'm wrong, I'll apologize, but I'm hardly ever wrong, right? So I never apologize. So ask my husband. So this is how I felt. I go there, and I'm like, when I get out, somebody's going to die. I was all like riled up, you know, and I was ready to, this is how I looked, I'm sure of it. It's me. And then I realized, you know, you've achieved success in your field when you don't know whether what you're doing is work or play, right? We love what we do. There are those days, I get it. But most of the time, we love what we do, right? I'm not going to let this guy, you know, mess with me. So I went back in there, and I said, Dad, and I talked to him, take him out of my advice to you is take that person out of that environment. There's something in there that's triggering them, right? So I took him into the consult room, and I said, tell me what's going on. You know, clearly you're upset about something. And then this guy, this lawyer, who's all tough ass, you know, started crying, and he said, you know, I'm losing control. We're getting divorced. I don't have any control of my kids. They don't respect me. And this was sort of his way of kind of regaining control. So we talked about how that doesn't look like that. You just look like you don't trust your kids. Can we do something a little bit differently here? So we got social worker involved. We went back in as a team, and I said, your dad and I have talked. Your dad has made a decision. And so he told the kids themselves, you know what? I'm not going to have you go through these tests. Not that I was going to do them anyway, but, you know, give them a win, right? Because I wasn't going to do it. And I could whip out all the articles and show, and there's AEP articles saying you don't have to do this test, and that could have been the route I took, right? We've got a policy that says, and I've had my partners have done that before. Our policy says we don't have to do that. It's not going to work, right? So give him the win, and by the end, everyone was happy and hugging and all that stuff and crying and whatever happened out of it, but diffuse that situation. So first thing was for me to realize I was getting annoyed and get out and take a breath, right? And then come back and do the right thing. Does that make sense? I'm sure you've had cases like this, and it could go either way. And that avoided him yelping at me. All right. 3 big drivers. I like to make things really simple. I have an ER doc brain. I can't handle too much stuff. And they give me surveys and phrases and stuff. You know, if you're not knocking on the door, and I tell you I do this all the time, I'm busy, poor patient's on a bedpan, right? And I go barging in and start listening to their heart and lungs, you know, because I'm busy, you know. And they haven't stopped, you know, at least knock so they can stop peeing midstream. You know, that's the least we can do, right, is give them a little notice. Knock, knock, Dr. Sharieff coming in, right? That's rule number 1. It shows that you're respecting their privacy. 2, we talked about sitting. There's a reason for that. And I've changed my question to, do you have any questions? And the first thing I ask when I go in the room is, what's your greatest concern today? Okay, think about that for a second. Versus what are you doing here, what brings you in, anything like that, because it'll get you to the root of the problem a lot faster than those, you know, at the end of the shift, then go, hey doc, by the way, can you look at this rash in the groin? Like, could you not have told me that in the first place? Because that's really what they're there for, right? You get to the root of their problem. And I'll tell you why this resonated with me. I told you I was a bit of a naysayer. I started using this phrase, and it was a 7-year-old that came in on the 4th visit. 3 different ERs across town, not all our sites, with leg pain. One leg, then the other leg, with low-grade fever on and off for the last week and a half. So now it's a 4th visit. My first thought is, you know, really, you should go to your primary physician. That's what everybody else has told you to do. And then again, I took a step back and said, they're here for a reason. And I asked the grandmother who brought the kid in what her greatest concern was. And she said, I'm concerned he's got cancer. And then the light bulb went off, right? You guys got it now, right? Roving pain, right? Low-grade fevers. Could it be cancer? So I said, okay, let's do this. Let's get a blood count. Sure enough, that kid had leukemia. Okay. I know, wow, right? That's my first case. So this is why it stuck with me all these years. Had I not asked that question, I probably would have blown the kid off, to be honest. I just had done an LP on a kid with meningitis. I had a trauma coming in. Kid looked okay, a little pale maybe now that I think about it, but I would have missed it, right? Because I wasn't going to do another x-ray. He'd been x-rayed already. And so that question has really made a difference in my practice, and I encourage you to start using that as well. Because patients sometimes don't want to ask you questions because they don't want to look dumb, right? And so it gives them that opportunity to really get to the root of why they're there and shows that you're concerned about them. Keeping them informed is huge. That's all over the ER survey. So I use a word that they're going to see. I want to make sure I keep you informed. I'm going to come back when the CT scan results are back, right? It's easy enough. So you look at your surveys, know what the questions are, and then just start using some of the words. They're all natural words, not like exceptional care. It's informed. You use that word every day, right? Out of respect for your comfort, I'm going to get you a blanket Out of respect for your privacy, let me draw the curtain while I do the exam or cover you up. These are things that are not that hard to say, right? If you get somebody saying thank you to you, oh, doc, you did a great job today, your staff was great, tell them they might be getting a survey in the mail. And some of my docs have said, well, that sounds like I'm a used car salesman. It's really not. Everybody's asking for a survey now, right? Burger King, my car dealer, everybody. They're even worse. They're like, give me a 5. If you can't give me a 5, tell me why you can't give me a 5. I mean, they're really pushy. We don't want you to do that, right? But you can at least get what, something out of it. And so you might get a survey in the mail. Really appreciate it if you fill it out. I'm more likely to fill it out if you ask me. I'll remember your smiling face and go, oh, you asked me, maybe I'll do that because you asked me. Otherwise, I'll throw it in the trash. The truth is the truth, right? I'm not likely to do it if I don't think that I should do it for you, okay? The one thing I don't like is we're doing our best right now. I'm sure you guys hear that all day long. The staff says it to the patients. Your best isn't good enough right now, right? They don't want to hear you're doing your best because you're busy. They want to know that you're trying. So all you have to say is, I apologize. I'm really sorry for making you wait. That's really the best thing that you can do at that moment. Instead of saying, do you have any questions, right? What questions do you have for me, right? That's more open. They're more likely to ask you a question then as well. We talked about the emergency thing to do. Oh, the last one on here, one of the docs was actually, the father didn't like what he was telling him, and he called him an idiot. He called the doctor an idiot. He goes, you're an idiot. The doc got very defensive, as we talked about earlier, and just started defending himself. I've done 1,000 of these procedures before, and I've done this and that and the other. Didn't help, because there was no way he was going to win that argument, right? So this doc actually couldn't sleep for a week. He said, this is the worst interaction I've ever had with any patient before. Can you come see me? I'm really distraught by this. And it does. It really kind of shakes you up when you have that kind of experience, right? And so I said, all you should have said was, I'm really sorry you feel that way. I clearly can't meet the expectations that you have. Let's see if we can find you somebody who can do that kind of procedure for you. I can't be that person. And done, right? So this guy got yelped, health grades, everything was all over about this poor physician when he really didn't do anything wrong, okay? Just take a breath, think how you're feeling, and get out of it. Just apologize. I apologize to everybody that's been waiting for me in the ER, even if it's been a few minutes. I'm really sorry for making you wait. Right? I'm here now. I promise you my full attention, okay? Unless a trauma comes in, But I promise you my full attention. Tell them if you're expecting a phone call, though, for real. If you're expecting a phone call, you should tell them, I'm here. I promise you my attention, but I am waiting for a phone call. I might need to take that, but then I'll be right back, okay, as well. My hands are tied. What do you want me to do about this? So I heard this from the nursing staff a lot of times. So the doctor has written for this, and what do you want me to do? That's not a nice thing to say. Think about how you would feel. We got I coached the hospitalists as well, and one night they heard somebody answer the call button. This is true on nights. What do you want? That's just not, how would you feel if you're the patient, you're calling for help, and somebody's asking, what do you want? Let's think about how to say that better. And then the worst thing we do is say nothing, right? People are standing at the door and they're really upset, and we don't acknowledge them at all. So you want to say, you look really upset, you look really frustrated, what can I do to make this better for you, okay? Angry patients, I see you're uncomfortable, I see you're upset about this, so your point is well taken, let me report that on, but right now I'm here to take care of you, right? Thank you for giving me the chance to address this matter, sort of the things. And then these are all tips on yourselves, and I'm running a little bit out of time here because I love this topic, but getting them to be involved in part of the decision making. I can tell you're really angry right now. Here's a couple of choices that we have. Here are the 2 plans that we can come up with for you. I really want to make this experience better for you, right? So read through some of those key phrases on your own. The anxious patient is a little bit easier. What I tell them a lot of times is, I don't know the diagnosis. They want me to tell them what the diagnosis is. We don't know that a lot of times, but it makes them feel better to say that sometimes we don't have the answer, but I've ruled out these top 2 life-threatening things for you. You're not having a heart attack, you're not having a bleed in your brain. Those are 2 really bad things that you're not having today, right? The rest I'll let your primary physician figure out. But we've ruled out some really bad things for you today. That makes them feel better, right? And always manage up, right? You want to acknowledge your team. You got a great nurse working with you. Dr. Sharieff's coming on. She's great. She's going to take good care of you. We don't do that enough for each other. And then this one slide that I'll leave you with as well, culture eats strategy for lunch every day. You guys have to have these conversations with your teams to decide how do you want to receive feedback. Because you can't let those grumpy people be grumpy anymore, right? It's affecting your livelihood. ED-CAPS is coming. Patients are coming to your emergency department. And so how does that look? Do you give them feedback in real time? Do you tell their managing supervisor? How are you going to manage that? I frankly would much rather the nurses tell me if I've been grumpy with somebody than to tell my supervising doc. That just doesn't feel good. So you guys have to go back to your groups and decide, but do not allow the grumpies to be grumpy forever after, right? Time has come for a change. All right. There's one slide in there about EHR tips, and I can talk to you about that in the break or a little bit later. But sometimes all you can do is pray that they leave your department. You know, you just pray that they leave you be. All right, it's never too late. So there's one thing I want you to take from this. You decide what one pearl you want to take home with you, and then we'll talk a little bit more about this a little bit later. Okay? Billy, sorry, it took a minute of your time here.